Thank you for joining us today. The first question is about syntax score. Would you briefly explain the good points and bad points of current syntax score for left main revascularization?
Yes, there are several points that we should discuss together. I would say that the syntax score is a very useful tool for interventionists in order to make a decision making and for patients undergoing left main revascularization. And for this reason, you know that in the current guidelines from both US and European side, syntax score has been adopted as a point that should be taken account. But there are some limitations and some good points of related to this score. I would say that the bad points of the syntax score are practical, first of all, because it's time consuming. It takes 6 to 8 minutes. There is some intra and inter-observer variability, which makes some confusion because different operators give different results in terms of syntax score, and also doesn't take into account some kind of lesions such as instant restenosis, saphenous vein graft, bridges, aneurysms, etc., etc. And this is the technical, negative point of the syntax score. But there are some other statistical points that we should take into account, because you know the best way to evaluate the score is analyzing the accuracy. Accuracy is determined by the discrimination and the calibration. Discrimination is the ability of a test to assign a certain degree of risk to each patient. The calibration is the ratio between the expected and observed risk. So in this case, we would say that the syntax score is able to discriminate, so is able to separate the low, very low risk from the very high risk, but is not well calibrated. In the middle class, the intermediate score patients are always not in the anticipated order. They should be in the middle between the low and the high score. They are not always in the middle, so should be improved. This is, from my point of view, the major limitation of the syntax score. But from another point, we could say that it's very useful because we, for the first time, we are able to compare the surgery versus PCI. We are able to say, even at long term, which patient can undergo surgery and which patient can undergo PCI. And we, by sure, know that the higher side patients need to undergo surgery because they experience too high rate of mortality if they undergo PCI, and they experience too high rate of revascularization, up to 33% of revascularization in the PCI group. On the other hand, if we look at the low or intermediate syntax score patients, we know that they have the same results, similar results than surgery. And this is a good point for us because guidelines changed according to these results.
We have the other risk scores like syntax, like NERS, CSS, GRC. So what is the best or most predictive risk score for the outcome?
So this is another point of interest, because what we know is that the syntax score is a standalone angiographic score. So we need to combine also other scores that take into account different information. And in this regard, the clinical and angiographic scores are, in my view, the most practical, and also money saving, because there are the functional scores, but they spend money because you have to use IRUS or FFR, which is useful, but is somewhat expensive, and not so many people, especially in Europe, are eager to use by routine IRUS and FFR. So going back to the combined score, the clinical score combined with angiographic score are the best tool, in my view, for evaluating the patient. Among the combined score, there are 3 scores: the clinical symptom score, the NERS, and the global risk stratification classification. The NERS, starting from the NERS is time consuming because it's 54 variables, and 4 of these variables are procedural variables, so you can assess the risk of the patient only after the procedure has been performed. So this is a negative point, and is able in discriminating and in evaluating many variables, MACE and soft and hard endpoints, but as I said, it's very time consuming and is a post-procedural analysis. On the other hand, we have the clinical symptom score, which is a combination between symptom score and ASEF score, which is age, creatinine, and ejection fraction score. And this is a good tool that only improves the discrimination only slightly in mortality in patients undergoing PCI, all-comers PCI, not left main PCI. So it has never been tested in the left main setting. So this is a score that is not the perfect score. The ideal, I would say the more ideal score, because we need to have the perfect score, we don't have so far, but the best tool so far is the global risk stratification, which is the combination between Euroscore and symptom score. And this score improves the ability in discriminating and calibrating the patient, providing very good results. If we adopt this global risk classification in the syntax trial patient, we are able to predict the 0% mortality in the low risk patient. And this is a very important point, because this tool is useful both for the risk assessment and for the decision making. Because for the risk assessment, we are able, with a good calibration and good discrimination, to give, to assign determined risk per patient. And for the decision making, we are able to say if a patient at very low risk score has a mortality very low as expected. And this is a very important point for the patient and for the physicians.
So in your view practice, what do you favor? What is your favorite?
So my favorite is the clinical symptom score, the global risk classification is what we adopt in current practice. By sure is that we don't adopt the scoring system in all the patients, because the very simple patients are too simple and there's no need for evaluation, as well as for complex patients who are very complex, and so we send to the surgeon without any discussion. For the intermediate patient, this kind of classification, so the global risk classification, is very useful for risk assignment.
This is the other subject about the corevalve.
Corevalve.
Recently, you presented the result of Italian corevalve registry. What is the result, and what can we learn from the result of this registry?
This is a very, very important point, because we presented 2 studies, one at 1 year with 664 patients, and another in the same population, all the eligible patients at 3 years, 101 patients. It's the longest and biggest series with the corevalve. And what we learned is something of importance, because we know that the technical success is achievable in almost all patients. So the procedure is safe and effective, but which are the results? Results are influenced in terms of survival at 1 year by some factors, independent factors. The short-term factors, 30-day factors, which account for 5% of the mortality, which occurs within 1 month, are most of them are technical factors combined with some clinical factors, such pulmonary hypertension or depressed ejection fraction. But so the technical factors are the problem occurring during the procedure: cardiac tamponade, vessel rupture, etc., arrhythmias. And after the first month's mortality, which accounts for 5% of deaths, we have slight and continuous increase, 1% per 100 patients per year per month. And this is an important point because we know that there is in such complex population a continuous increase in mortality, which raises up to 15% at 1 year. So we have 1% per month mortality. But if we look at 3 years follow-up, we see that 35% of patients died, but only 1/3 of this patient died for cardiac disease. Most of the patients died for other causes, which are linked to the elderly age and the complexity of the patient. Another point is that the paravalvular leak are a strong independent factor. They increase almost 4 times the mortality in patients undergoing TAVI. So the importance of evaluating and reducing at maximum level the degree of paravalvular aortic leak is important, because we know that one of the major limitations of the corevalve as well as for the Edwards valve is the residual aortic insufficiency, which affects, as demonstrated by our study but also by the partner study, affects the survival of the patients.
Do you have any tips and tricks to reduce the paravalvular leakage during the procedure, especially in the core valve?
Yeah, what we do in the core valve, first of all, the correct evaluation of the patient is one of the key factors, because you have to assess the degree of calcification and the correct size annulus as diameters, and also the sphericity of the annulus. I would say that the best way for reducing the paravalvular leak is the correct positioning of the valve and the correct sizing. Especially in borderline valves, we prefer to implant the larger size valve instead of the equal size valve. I mean, if we have a 44 millimeters annulus, we implant the larger valve instead of the small valve. This is the only way to reduce the paravalvular leak. In some cases, we implant a valve-in-valve or valve-on-valve, which is a safe procedure that gives at 1 year same results than a single valve implanted patient.